I appreciate the opportunity to present today. I'm going to be talking about weight stigma and discrimination and put this in a larger equity framework approach and borrow some of the work of Dr. Kumanika here in the audience. I have no disclosures. So I want to begin with the idea of what is health equity and pulling from the words of Dr. Braveman from RWJF and her colleagues. Health equity, they define as meaning that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and a lack of access to good jobs with fair pay, quality education, housing, safe environments, and healthcare. And next, I'd like to show you a quick snapshot of an illustration of Dr. Kumanika's equity-oriented prevention framework, which, as many of you may know, is designed to guide selection of interventions to reduce disadvantage and improve equity. I'm going to call attention to the upper right quadrant here, which is focused on policy and systems change interventions. And in particularly, what I'm going to talk about for the next few minutes are threats to personal safety, discrimination, and social exclusion. I'm going to provide strong and consistent evidence that weight stigma and discrimination are threats to health equity for people living in larger bodies. So we'll start with the first point around discrimination and social exclusion. And I'll propose one approach to address this equity problem would be to ban weight discrimination. Weight discrimination is widespread, it's legal in most places, and it's an obstacle to basic rights and health. And yes, you still can be fired for being fat from your job. If you hadn't seen this, I suggest take a picture of the QR code or the URL here. It's an excellent piece on discrimination in employment. Weight discrimination, a great deal of research has accumulated around stigma and discrimination. So by stigma, what I mean is disparaging associations of negative personal characteristics with larger bodies. Discrimination is well documented in employment, education, healthcare, public health, public settings, and more. Experiences of discrimination are linked to lower earnings, people being less likely to be hired or to be promoted, more likely to be fired. Also, lower subjective ratings by teachers in school settings and college admissions. And also inaccessible public settings and social isolation. And finally, all of these are linked with higher risk for depression, anxiety, eating disorders, harmful physiological impacts, or what we've heard talked about as allostatic load, the stress response, the physiological stress response to discrimination. I want to share just for a moment a report that my group, Stripes Strategic Training Initiative for Prevention of Eating Disorders, put out last year, collaborating with Deloitte Access Economics and funded by Dove Self-Esteem Project, which is a program within Unilever. And with this report, we estimated and provided what is so far is the most comprehensive social and economic costing of weight discrimination in the US. With this take-home point here is that we estimated that weight discrimination costs the US economy $200 billion per year. And with the QR code here, you can see the whole report, or you can see a snapshot on our website. We've costed out health system, productivity losses, wage losses, employment losses, other kinds of costs adding up to around $200 billion per year. This is an annual recurring cost, plus an additional $200 billion in lost well-being, which is a typical economic research metric. Now, there is some progress that has been made on discrimination in the US. We know that around 12.3 million people in the US live in areas with weight anti-discrimination law protecting them. We know that another 1.9 million people live in areas that have protection from weight discrimination by court ruling. That's basically the state of Washington. But what that means is that 95.7% of people living in this country, in the US, live in areas with absolutely no protection against weight discrimination. And you can see it on the coast here. There's two states that have some kind of protection, Washington and Michigan. The green states here, it's actually just the city where the yellow star is. And to quote the Rudd Center's powerful policy brief on weight bias, as they wrote, quote, without laws to protect weight discrimination, to prohibit weight discrimination, people will continue to be unfairly fired, suspended, or demoted because of their weight, even if they demonstrate good job performance and even if body weight is unrelated to their job responsibilities. I want to mention a collaboration of a couple of fat activist groups, as they refer to themselves. FLAIR and NAFA have joined with Dove. Again, Dove is Self-Esteem Project is funding a national advocacy campaign launched last month to try to get legislation through to prohibit weight discrimination across the country. I'm going to give an example. In the state of Massachusetts, we have two lawmakers. They had been working on this before that coalition was announced. Senator Roush in Massachusetts and Rep. Wynn in Massachusetts are leading an effort to get legislation through in Massachusetts. We have no protections in the state. I'm from Massachusetts, but they're trying to change that. Now, the second problem I mentioned, looking again at the framework, is the equity problem of threats to personal safety. And an equity solution for this might be to eliminate barriers to care. And as a reminder, I'm pulling from that upper right-hand quadrant from the equity-oriented prevention framework there. With barriers to care, we know that this is a threat to the safety of individuals, their health and safety, and improving care, improving access can improve quality of care for people living at higher weights. So it's easy. I'm sure everyone agrees in the room that identifying and mitigating barriers to care within a healthcare system will be critical to improving access to quality care. But what's not so easy to agree on is what the barriers are and how to mitigate them. So I'm going to put forward one idea just to float this idea out there today. The idea of universal weighing, could this possibly be a barrier to care? And what do we know so far? Now, when I say universal weighing, what I mean is the routine weight and BMI surveillance. We've heard a lot about it today. This is a kind of surveillance that is ubiquitous. People out in the world are experiencing this constantly in healthcare, in online digital apps, in school, in work, in athletics. People are getting weighed or they're being assessed around their BMI all the time. That's the lived experience for everybody in this country. So I want to offer the idea, let's bring a SWOT analysis. We heard from Dr. Ogden, pluses and minuses, so SWOT just adds a couple more levels to this. As many of you may know, the SWOT analysis is strengths, weaknesses, opportunities, and threats. It's meant to bring a systematic approach to assess programs and systems to see if there's ways they could be helpful and ways they may be harmful, what may need to be changed. So I'm going to propose today that we bring a SWOT analysis to the idea of the ubiquitous weighing or BMI surveillance. Clear strengths, dosing medications, crucial with children, tracking child growth, targeting equity efforts. That might be internal strengths of the universal weighing or BMI surveillance. An external positive could be alerts to impacts of interventions, monitor trends in society, and again, inequities. These are opportunities on one side of the SWOT. On the other side, though, we have the weaknesses, and I'll get to threats. Weaknesses, as we heard all day today, BMI is a poor proxy for individual health. Really can't function as that for that purpose. When there's something that is done throughout the healthcare system and other settings that's not gathering information that's being used to improve healthcare, that's a waste of time and money, just to put it bluntly there. And threats. We've heard from the presentations on lived experience and other presentations that in the context of rampant weight stigma, that this can cause avoidance and subpar care and shame. These are very negative threats that this kind of constant surveillance it can be leading to. I'm going to leave you with one quote we heard in the beginning of the day, a quote from Aubrey Gordon. I'm going to offer you another one. Quote, I had good insurance, plenty of doctors nearby. I had all the access I needed, but there was just one problem. I was fat and I couldn't seem to find a doctor who would take my symptoms seriously. So for the better part of a decade, I abandoned the medical care that had long since abandoned me. So what can you do? I'll offer a few thoughts before I wrap up here. You could conduct, and the folks out in the audience, you could conduct your own SWOT analysis. Where, how, and why do you require or encourage routine weighing? Could this be a barrier to care or stigmatizing? How might these practices disproportionately burden BIPOC, low income, and other minoritized communities receiving care, perhaps through public systems, as an example? What are the equity costs of excessive surveillance, particularly data that's not being used? Can you include SWOT analysis in your SWOT analysis, voices of people with lived experience, as we've heard today, and in your own work? People with lived experience with weight stigma. Do your community advisors currently include these voices? And a few resources here for where to find instructions about how to use a SWOT. It's very straightforward. I want to leave you with two quotes, one from a physician here in the Washington area describing how she approaches this issue, knowing that there can be threats to her own patients and be a barrier to care. As she wrote, she said, quote, "I delay weighing new patients so I can make sure doing so would not cause harm, like in the case of clients with eating disorders or a history of body shame." So she just doesn't do it on the first appointment. She waits to get to know a patient. Could be a simple change to reduce the harm or the shame caused by this. And a final quote from a roadmap my own organization published a couple of years ago about public health and how we can address weight stigma in our field. A quote from our report, the roadmap: "Research is mounting showing the pernicious effects of weight stigma on health. As public health professionals, our responsibility is to root out the practices and systems that perpetuate weight stigma." Thank you.